popped into my mind thinking about urologic problems. There is something called sacral nerve stimulations. It's very similar to deep brain stimulators, but instead of inserting the little wires into the brain, the urologist and some pain management doctors as well will insert little wires in the sacral nerves. So these wires go into the sacrum on the bottom of your tailbone, and those nerves actually are the ones that control your bladder, your bowel, and all that. So that's an FDA-approved procedure, and there's 1 or 2 companies that's already in works. I don't know that many urologists that would do here in San Antonio, but probably Dr. Harper and Dr. Albert. So speak with your Parkinson doctors about sacral nerve stimulation for your urologic problems if nothing else works.
Next, the last question in this section.
Hi, it's just 3 questions. One about, what are your thoughts on alcohol and Parkinson's, like drinking a margarita? And what are your thoughts on protein affecting absorption? And does your body weight actually, does your dosage of medicines relate at all to your body weight?
Okay, 3 good questions. I'm going to throw the alcohol question to Dr. Alvarez. Because Dr. Yankov isn't here today.
That's right. No, I was just wired me on alcohol. I can barely tolerate 2 ounces. Asians don't have the enzymes to break it down. So the first question is Parkinson and alcohol. Well, there are many reasons why I will not promote alcohol, although it's good for certain people, but not in the setting of Parkinson's disease. One reason that comes to my mind is Parkinson's patients are already unsteady, right? They have inability to balance, prevent falls, and you can have a worsening of this ataxia if you are intoxicated. Alcohol can also impair your cognitive function, your reasoning, your judgment. Remember, these Parkinson patients can have this problem as well. So the mobility and the cognitive functioning can be impaired. Not to mention, we are prescribing Parkinson medications, and the potential side effect of medications will be enhanced if they take alcohol. So those are the top 3. I'm only answering part 1.
That's fine.
Right?
So, yeah, just to reiterate, so some people will find that alcohol obviously lessens tremor, but the problem is that there's a rebound effect when the alcohol wears off. Also, alcohol is a neurotoxin, and so chronic use, certainly at certain levels, can further damage the nervous system and enhance balance problems. So it isn't an appropriate long-term treatment. Now, say, you're giving a speech and you need a temporary reduction of tremor or anxiety. Well, then perhaps it's useful in that setting, but not as a chronic daily treatment, okay? So that's how I would have you look at it. The second question was, what about protein? So protein is broken down into amino acids. All right, so amino acids are essential for life. You must have protein for building blocks of various components of your body, including your muscles, obviously. But levodopa is like an amino acid. So in the first part of the intestine, both regular amino acids and levodopa are absorbed. So if both of them are there at the same time, they can compete for transport from the intestine into the blood. So in patients who have ups and downs, where the medicine is wearing off or not kicking in, obviously redistributing when you have protein in relationship to the levodopa is useful, because that reduces the competition, which also occurs from the blood to get into the brain. So there's a reason then to redistribute. Not eliminate, because it's essential, but perhaps redistribute the protein to later in the day when you may be at home or not active. Okay? And then the last question was?
Body weight.
Body. Yes. So, drugs, the question is, does body weight influence the effectiveness of drugs, basically? So, remember, drugs are absorbed into the blood and then have a distribution throughout the body. So if you have more of you then the drug gets distributed into the fat cells and things, places where we don't need it to go. So less is available to get across the blood-brain barrier into the brain. And so it's important to recognize that weight also has an effect on effectiveness of drug, not only dopamine that we showed in the animal models slide earlier, but also in its distribution in the body. So, all right. So very good question. So we're going to move on to our next section. So this is going to focus on levodopa because oftentimes I have patients worried about starting levodopa. They've read it only works for a certain amount of time, or it doesn't work later in life. So they want to save it for later. And that saving is an inappropriate concept. And so we're going to talk about where is the pendulum today. So using early levodopa, using late levodopa, what is the science that guides us in this decision making? And it's important to recognize that levodopa was first introduced in the late 1960s, and it produces a major symptomatic benefit for Parkinson's disease. It remains, despite everything that's new, despite all of our very nice sponsors and their drugs, it remains the most effective anti-Parkinsonian medication, the most effective. It remains the gold standard. And every new therapy must be compared against this gold standard. But there have been these concerns that have prompted patients to worry about the potential toxic effects. Does it accelerate the loss of dopamine cells? Does it lead to free radicals and killing of cells because of those toxins? And so we're going to touch a little bit on that. We're not going to get too deep, but we're going to at least alleviate some of the concerns. So again, this just shows you how levodopa works. Remember, we said it has to be mostly swallowed, although there are other forms now, including the inhale, but mostly swallowed, gets into the stomach, has to get through the stomach, into that first part of the intestine, then it goes across a transporter, competing with amino acids that are part of protein, gets into the blood, and once it's in the blood, it can be available to get into the brain. Now, when it's in the blood, the body tries to convert it to dopamine. You'll see at the left, levodopa down to dopamine. But we don't want it to turn into dopamine. You think, well, why not? Well, I need more dopamine. Well, dopamine doesn't get into the brain. So when levodopa gets converted to dopamine in the bloodstream, it's not useful. And so you might have watched the show Awakenings and some of the other shows about certain forms of Parkinsonism, where they have to use really high doses in order to have just a little bit left to get across the brain. Well, in the 60s and early 70s, we developed a new drug called carbidopa. And carbidopa blocks that conversion to dopamine in the blood, so the levodopa is in the blood at a high enough level to get into the brain. So if you don't have enough carbidopa, you can have side effects from levodopa. And so many times patients come to me their first visit, well, I tried levodopa, I can't tolerate it, I get nauseous or I get lightheaded. Well, it's because they didn't have enough carbidopa. And so sometimes we'll add plain carbidopa to the carbidopa levodopa. Because when you look at your carbidopa levodopa, it has 25 milligrams of carbidopa, 100 milligrams of levodopa generally. Most people need about 100 milligrams a day of carbidopa to prevent the side effects and allow enough levodopa to get into the brain. So if you're taking a half of a 25-100 tablet, you're only getting 25, twice a day, you're only getting 25 milligrams. So sometimes we'll just add plain carbidopa. So that's an important point of using levodopa. Levodopa gets into the brain, into those remaining dopamine-producing cells, converted to dopamine, and that is what's active. So it's important to recognize that insofar as utilizing levodopa. So it's shown that it reduces short-term disability. very effectively. So it improves the symptoms that we've gone over already, the slowness, tremor, balance, rigidity. However, after about 5 years of disease and use of the medicine, about 50% of patients develop what we call motor complications. By 10 years, nearly every patient has these motor complications. That doesn't mean that levodopa isn't working. It's just working for a shorter duration of time or associated with these extra movements which we call dyskinesias. Okay? And sometimes they're not disabling. They're minor and patients don't need anything done about them. But sometimes these off periods, when the levodopa wears off, they can cause disability, or when the dyskinesias occur. But despite this fact, levodopa remains the most effective agent overall, despite that fact. Okay? So let's talk a little bit more about this issue. Again, it's a gold standard. Okay, so laboratory studies, and I'm not going to go into that in depth, have shown that levodopa is an oxidizing agent. What does that mean? Well, it produces free oxygen radicals, but that's in petri dishes and in animal models. Okay, so it's been only shown there, but when we've tested it in animals themselves, it's not toxic to the dopamine neurons. Now, it produces these toxins in cell cultures, but it doesn't kill the dopamine neurons in the animals. And it's not really clear how the production of these oxygen radicals relate to the use of levodopa in patients. Okay, so it's important to recognize that. So studies have looked at the use of levodopa in patients. And there have been both retrospective and prospective studies. Studies that look backwards, studies that look forward. And so in retrospective studies, the rate of progression in disability and mortality was similar, whether patients used levodopa early or whether they used it less, so later in the disease. So it didn't make a patient worse over time or lead to death earlier. So suggesting that there was no advantage in delaying the initiation of L-DOPA treatment. Another study going forward looked at patients who received levodopa or some other agent. And in this case, it was either dopamine agonists or those MAOB inhibitors. Looked over 3 years, and those that were on L-DOPA were not worse, but slightly better when L-DOPA was stopped, and they looked at how the patient was without treatment. So again, data that doesn't suggest that it hastens progression. In 2 other trials, however, patients were early and untreated, and then they were treated with either levodopa or either Mirapex or Requip. But the endpoint in these studies were to look at those scans that I showed you earlier, the DAT scan or PET scan, looking at a biomarker of the function. Remember I said the DAT scan isn't useful to look at progression. It just gives us a snapshot. And in these cases, the rate of decline in those scans was greater in the levodopa group. But that may result not necessarily because levodopa was toxic, but because levodopa has effects on those scans and that dopamine transporter protein. And so again, inconclusive evidence that it's toxic at all. Some of you might have participated in this trial. This took early patients and gave them L-DOPA at different doses versus placebo. The top line is placebo, the next line is 150 milligrams a day of levodopa, next 300, next 600. And then they washed out at the end. You see withdrawal of study drug. And you see the change in this total score. So the higher the score, the worse the patient. You see when levodopa was stopped at these different doses versus placebo, the placebo group was worse after starting exactly the same. Again, suggesting that using levodopa across these doses didn't result in patients being worse down the line when all the drugs were stopped. So again, data that doesn't support delaying levodopa. So there's no direct evidence in the clinical studies that it adversely affects the rate of progression. There is even the possibility that it slows the rate of motor progression by that one study. And I've already mentioned that the two imaging studies that showed that the levodopa group was worse versus the other agents may have been a factor on how levodopa affects dopamine cells. So we've talked a little bit about the motor fluctuation. So you'll see the top graph, a patient takes the medicine, they're at the bottom in the red, they're not doing well. They get into the green, that's when they're doing their best. Some patients get into the top red area, that's when they have the twisting, turning movements. And so over time, after having the disease for years and being on medicines, these ups and downs happen throughout the day. And so the good clinical response to levodopa on the far right bottom becomes a narrower window. So we have to adjust the dose more tightly, maybe less levodopa more frequently, or other agents to work with levodopa. But levodopa still provides benefit despite these ups and downs. Now, one other thing to mention is on this slide. So we've talked about the on and off periods and the dyskinesias. But there is also this issue of increased frequency of melanoma in patients. And this was, in the past, thought perhaps it related to levodopa. But when this was looked at in detail, the increased risk of skin cancer in Parkinson patients relates to the underlying disease and not to the exposure to any specific drug. And so all patients should have a yearly skin exam to screen for the possibility of melanoma, not those just on levodopa. Okay. All right, so what are the conclusions and recommendations based on what I've shown you? So it's clear that levodopa reduces disability. It remains the most effective drug. There's no evidence in humans indicating that treatment is toxic. No good evidence that it has an adverse effect on the rate of progression, and no evidence that it increases the risk of death in Parkinson's patients. So it's universally recommended, and so the therapy should not be restricted. That doesn't mean everybody starts it when they have a diagnosis. When their disability warrants the use of levodopa, it shouldn't be withheld just because of some fear that I've hopefully alleviated with the presentation. The doctor should always use the lowest dose that provides satisfactory control of whatever the disability is. And higher doses, though, shouldn't be withheld when it's required. But we generally like to keep patients between 400 to 600 milligrams of levodopa a day unless their disability warrants. And there is no maximum dose. Oftentimes that's a question, well, am I at the maximum dose? We have some patients who are on 1,000 milligrams a day, some patients on 2,000. It just depends. It's a rarity, but it depends on whether their disability warrants. So that's where the pendulum is today. So the pendulum, I say, is in the middle. It should be used when it's necessary and not delayed just because of the fear